everyone, and welcome to our model on drug interactions. In this model, we're focusing on the two types of drug interaction, which includes pharmacokinetic interaction and pharmacodynamic interactions. Now, as a form of definition, drug interactions are described as pharmacological results, either desirable or not, seen when we use two drugs concurrently, um, or when we use a drug with another substance of a particular state. Typically, when we talk about drug interactions, we're talking about interactions of two drugs. But we could also have interactions between drugs and other substances. Some of the other substances to which drugs could interact with would be food, herbs, endogenous substances, chemicals used in diagnostic testing, laboratory test itself, diseases, and genetics. So when we talk about drug interactions, it's important to note that we are not restricting it to just drug-drug interactions. We could have drug and other substance interactions as shown on the screen. But with respect to the particular course or topic, we focus largely on the drug-drug interactions because these are the common forms of interactions that we see. There are four major types of drug interactions, although the first two drug interactions are the point of focus for this particular model. The four types of drug interactions include pharmacokinetic interactions, pharmacodynamic interactions, pharmacogenetic interactions, and pharmaceutical interactions. It's important to note that the outcomes of these types of interactions could either be an enhancement of drug action, which there's an improved therapeutic benefit for one drug as a result of the effect of the second drug that was used concurrently or second substance used concurrently. Another outcome of drug interaction could be reduction in desired effects. So one drug could affect the effect of the second drug, and as a result, that can lead to therapeutic failure. You could have neutralization of drug effects, or you could have an increase in the risk of adverse reaction. So these are the repercussions of using two drugs concurrently that tend to interact with each other. Let's start with the very first type of drug interaction, pharmacokinetic interactions. Pharmacokinetic interactions refers to the type of drug interactions whereby the pharmacokinetic properties of one drug is affected by the second drug or second substance that was used concurrently. Remember that the pharmacokinetic properties of a drug includes the ADME of the drug. So pharmacokinetic properties of a drug that can be affected when used concurrently with the second substance would be the absorption of the drug, the distribution of the drug, the metabolism of the drug, and the excretion of the drug. Once either of these components are affected, we would say that that type of drug interaction is referred to as a pharmacokinetic drug interaction because the components of pharmacokinetics were altered when we are using the drugs concurrently. Starting with the first component of pharmacokinetics and how it could be altered in a pharmacokinetic interaction. There are four major ways in which absorption could be affected when we use two drugs concurrently. It's either through a process called adsorption or through a process called formation of complex that are not absorbed, or through increase in gastrointestinal transit time, or through the alteration of gastric pH. So if we are using two drugs concurrently, drug A could affect the absorption of drug B through either of these four mechanisms. So here are examples of drug interactions whereby absorption could be affected when we are using two of those drugs concurrently. And like I said, there are various mechanisms by which absorption could be affected. If it's in the mechanism of absorption, examples could be when we use antacids concurrently with paracetamol or charcoal concurrently with paracetamol, or when we're using antacids or charcoal concurrently with H2 or histamine 2 receptor antagonist. In this case, what will happen is that the charcoal or the antacids will bind together with the paracetamol or H2 blocker and thereby reduce the absorption of this drug. So the Drug B, in the case paracetamol and H2 blockers are the ones affected in terms of the absorption. Another mechanism of absorption could be another mechanism by which absorption could be affected could be in the formation of complexes, and these complexes would not be absorbed into the GIT. Examples of this would be when we use antacids concurrently with tetracycline, or when we take milk concurrently with tetracycline. This is one reason why, when prescribing tetracycline, we prefer to use it on an empty stomach and not combine with any other food molecule, because combination of a food molecule that contains calcium or magnesium could eventually affect the absorption of tetracycline, and the mechanism by which this occurs is through the formation of complexes. Another example could be cholestyramine and digoxin. When we use these two drugs concurrently, cholestyramine could affect the absorption of digoxin by combining with it to form a complex, and this complex will not be absorbed into the GIT. The other two mechanisms by which absorption could be altered in pharmacokinetic interaction includes increase in gastrointestinal transit time and increase in or alteration in the gastrointestinal pH. There are examples under each of these two mechanisms, starting with the increase in gastrointestinal transit time. Concurrent use of antimuscarinic agents together with paracetamol or levodopa could affect the transit time of paracetamol and levodopa. Remember that transit time or duration of stay of a drug within the GIT can affect the rate of absorption. So, in the case of these two drugs, concurrent use of these two drugs with as antimuscarinics, absorption could be altered as a result of increased gastrointestinal transit time. Another mechanism could be alteration in gastrointestinal pH. So examples would be concurrent use of antacids together with ketoconazole, concurrent use of H2 blockers concurrently with ketoconazole. In the case of this, pH of the GI would be interacting with pH of ketoconazole, and if there's an alteration in the pH, that would affect absorption. Remember that the golden rule for pH in relation to the absorption of drugs would be that drugs that are weak acids are better absorbed in acidic environments, and drugs that are weak bases are better absorbed in basic environments. So in the case of this, ketoconazole is a weak acid. If we change the pH of the GI by using antacids or H2 blockers, which will make the pH to be more alkaline, the absorption of ketoconazole will be reduced because ketoconazole was going to be placed in a basic environment as a result. And this is just a way in which absorption could be altered with respect to alteration in gastrointestinal pH. Distribution is the second component of pharmacokinetics that could be altered or affected when we have two drugs being used concurrently. Typical examples of how distribution could be altered would be in the displacement of protein binding site. Remember that plasma proteins are very crucial in the distribution of drugs across the bloodstream. And if we have a scenario where two drugs are fighting for a particular plasma protein, the binding site of a particular plasma protein, distribution of one drug could be altered as a result of the presence of the other drug. So typical examples would be concurrent use of warfarin together with valproic acid. The two of those drugs will be fighting for the protein binding site, and one of them will be displaced. Warfarin might be displaced by valproic acid on the protein binding site, or vice versa. Another example would be in concurrent use of valproic acid with phenytoin. Valproic acid could as well displace phenytoin, and you could have large amount of phenytoin present unbound in the bloodstream. With respect to metabolism, which is the third component of pharmacokinetics, there are two major types of drug interaction or mechanism of drug interaction that we see with metabolism. The first is enzyme induction, the second is enzyme inhibition. Remember that for metabolism to occur, we need enzymes to break down drugs, and drugs are usually broken down using two major phases. Phase one involves functionalization reaction, phase two involves conjugation reaction. And both phases are going to be making use of enzymes that are either microsomal or non-microsomal. So drug interaction at the metabolism level typically involves two major mechanisms, enzyme induction and enzyme inhibition. When two drugs are given concurrently, and one of those drugs is metabolized by a particular enzyme, you could have a scenario where the second drug could be an enzyme inducer or enzyme inhibitor, of the enzyme that is metabolizing the first drug. So to use this diagram to explain the concept of pharmacokinetic interaction at the metabolism level. So imagine we have drug A and drug B being given concurrently, and imagine a scenario where drug A is metabolized by enzyme A into a metabolite. If drug B is an enzyme inducer of enzyme A, what will happen is that once we give these two drugs concurrently, drug B would induce the enzyme A, stimulate the enzyme, and thereby this will lead to excessive metabolism of drug A. So we have drug A being converted more into the metabolite. Whereas we could have a scenario where drug B is an enzyme inhibitor of enzyme A. If drug B is an enzyme inhibitor of enzyme A, what you would have when we are giving these two drugs concurrently will be that drug B would block the metabolism of drug A, and thereby we have more of drug A accumulating in the blood. This picture explains once more what we talked about regarding the pharmacokinetic interaction at the level of metabolism. As you can see, when we give two drugs, drug A and drug B, and one of the drugs is an enzyme inducer, what would happen is that the enzyme inducer would induce the enzyme metabolizing the second drug. So in the case of this image, drug A is an enzyme inducer of this particular enzyme, and as a result, if it induces the enzyme, the metabolism of drug B is going to be increasing as a result. So induction of the enzyme leads to the increase in the metabolism of drug B. Whereas if there's an inhibition of the enzyme, if the drug A is inhibiting the enzyme that breaks down drug B, what happens is that there's going to be an increase in the amount of drug B present, and there's going to be reduced metabolism of drug B. It's important to note the repercussions of enzyme induction and enzyme inhibition when it comes to pharmacokinetic interaction. When we're talking about enzyme induction, remember that the one of the drugs is going to be inducing a microsomal cytochrome P450 enzyme, typically of the second or concurrently used drug. And as a result, this will lead to an increase in the metabolism of that co-administered drug. The repercussion of this particular type of pharmacokinetic interaction is that there would be therapeutic failure, and this is because of the fact that the second drug will be metabolized in excess, and there will be very small concentration of that drug present in the bloodstream. Hence, the drug is not going to be effective because the therapeutic dose needed to cause an effect is going to be absent, and as a result, this will cause therapeutic failure. Examples of drugs in history that are being categorized as enzyme inducers include drugs like phenobarbital, phenytoin, rifampicin used as an anti-TB agent, carbamazepine, chronic alcohol consumption, St. John's wort, and glucocorticoids. The repercussions of enzyme inhibition are distinct from enzyme induction. For enzyme inhibition, remember that the concurrent use of one drug could have one of those drugs inhibiting a cytochrome P450 enzyme that is meant to metabolize the second drug, and as a result, this will decrease the metabolism of the co-administered drug. So for enzyme inducer, there's an increase in the metabolism. For enzyme inhibition, there's a decrease in the activity in the metabolism of the co-administered drug. Because there's a decrease in metabolism of the co-administered drug, this will lead to increase in concentration of that second drug, and as a result, this could present with increased adverse effects or drug toxicity. So in the case of enzyme induction, what we see is therapeutic failure. In the case of enzyme inhibition, what we see is drug adverse effect or toxicity. Examples of drugs in history categorized as enzyme inhibitors are drugs like cimetidine, ketoconazole, fluoxetine, which is typically used in treating depression, disulfiram, erythromycin, acute alcohol consumption, and the use of grapefruit juice. So here's a case study for us to try out. Mr. KP, a known alcoholic, was to undergo a major surgical procedure. He was placed on general anesthetic agents and was expected to put him to sleep prior to the surgery. However, the surgeons were having difficulty attaining anesthesia. Hence, they had to increase the dose of general anesthetic. What type of drug-drug interaction has occurred? And if you pay careful attention to this case study, we have two major concurrently used drugs. The first is alcohol. Is a chronic alcoholic, so is consistently on alcohol, which is the first drug, and then is being placed on general anesthetic agent, which is the second drug. And what we can deduce from this particular case study is that the second drug, general anesthetic agent, had failed therapeutically. There was therapeutic failure, evident by the fact that there was difficulty in attaining anesthesia. So from this, we can infer that the drug B, which is chronic alcohol consumption, had led to an enzyme induction of drug A, which led to metabolism of drug A, and as a result, therapeutic failure of drug A. The second case study for you to try on Mrs. J.A., a known peptic ulcer patient, was brought into the emergency room on account of continuous bleeding. On thorough evaluation, you discover that she recently was placed on warfarin, and she concurrently used this with omeprazole, prescribed by which was prescribed for managing an ulcer symptoms. What type of drug-drug interaction occurred? In this case, we are also having a case of two drugs being used concurrently, warfarin and omeprazole. And what we deduced from this case study was that she was having continuous bleeding. The continuous bleeding will be as a result of the warfarin toxicity. So because warfarin was being is being toxic in this particular case, which is evident by the continuous bleeding, we could infer from this particular case study that the omeprazole being used concurrently with warfarin led to an enzyme inhibition. And as a result of enzyme inhibition, what happened was that the concentration of warfarin increased due to reduced metabolism, and we are seeing more adverse effect of warfarin, which is the continuous bleeding. So in case of the drug-drug interaction in this case is enzyme inhibition. The last component of pharmacokinetic interaction is excretion. Excretion, remember, is the removal of a drug from the body. In terms of excretion and how it can be altered when we are using two drugs concurrently, there are two major mechanisms. First could either be an alteration in the renal blood flow. Remember that the kidneys are the commonest site of drug excretion, and the process of drug excretion by the kidneys involves glomerular filtration, tubular reabsorption, and tubular secretion. If there's an alteration in the renal blood flow, this could affect glomerular filtration, and as a result, the drug is not going to be entering into the glomerulus and the renal tube, and as a result, the drug is not going to be excreted from the body. So alteration in renal blood flow examples could be when we concurrently use hydralazine together with digoxin. Hydralazine could affect the excretion of digoxin, and as a result, you could have a buildup of digoxin due to the problems of alteration in the renal blood flow. Another mechanism or by which excretion is altered could be alteration in the active tubular secretion of the drug. Remember that tubular secretion tend to increase excretion of the drug through the renal tube. And if there's an increase in the active renal tubular secretion, this would further increase the excretion of the drug. Whereas if there's a decrease in active tubular secretion, this would decrease the excretion of the drug. In the case of the two drugs, probenecid and penicillin, when we use these two drugs concurrently, what would have as a result is that probenecid would reduce the active tubular secretion of penicillin. As a result, this reduces the excretion of penicillin, and penicillin will be stuck within the bloodstream. This is actually clinically relevant because we can use this as a result in increasing the duration of action of penicillin, because with probenecid, penicillin would remain in the bloodstream and it could work for a long amount of time compared to its typical duration of action. So this is one way in which we can manipulate penicillin um, by affecting its excretion and thereby improving its duration within the bloodstream. Second type of drug interaction is pharmacodynamic interaction. Now, for this type of drug interaction, what tends to be described is that the concurrent use of two drugs could have a scenario where the pharmacodynamic effect of one of those drugs is affected by the presence of another drug or another substance. Remember that aside drugs, you could also have a drug substance interaction. So substances like chemicals, food, or herbs could be um, playing a role in drug interaction. So from our previous model with regards to pharmacodynamics, remember that pharmacodynamics entails drug action, drug effect, and the dose response relationship. And as a result, these are the pharmacodynamic effects that could be altered when we use two drugs concurrently. There are four major outcomes of a pharmacodynamic interaction with respect to the drug effect. And these four outcomes could be either um, an addictive outcome when we use two drugs concurrently, the synergistic outcome, a potentiated outcome, or antagonistic outcome. I'll talk about each of these different mechanisms or outcomes in the next slide. Starting with an addictive outcome. So when we use two drugs concurrently and they produce an addictive outcome, this means that the combination of the two drugs um, results in an enhancement of the effect, in which these two drugs, it's important to note that they individually have their own separate effect, but once you combine them, there's an equal summation of effect. So think about a scenario where we have one drug being combined together with another one. The first drug has 100% activity, so that 100% activity is represented by 1. Second drug has also 100% activity that's represented by 1. And when we combine these two drugs and we use them concurrently, there's an enhanced effect of 200% or 2. A typical example is when we combine two drugs like paracetamol and ibuprofen. These two drugs are used as painkillers, and when we combine these two drugs, are very, very effective, and they have addictive effect in curing or treating conditions that have to do with pain. They tend to relieve pain to a higher degree than when we use them individually. So this is a typical example of an addictive drug combination which will combine paracetamol and ibuprofen. This particular type of drug would work more effectively compared to using either paracetamol or ibuprofen individually, because the combination that we tend to get from this is kind of an addictive combination. If paracetamol is causing an 100% effect and ibuprofen is causing an 100% effect, combination of these two would lead to 200% effect. Second outcome of pharmacodynamic interaction with respect to drug effect could be potentiation. Potentiation refers to the enhancement of effect of one drug by the second drug that was used concurrently. And it's important to note that one of those drugs would typically have an effect. So let's say one of the drugs is having 100% effect, but the second drug tends to have no effect at all whatsoever. And we tend to remember this by one drug being 100% plus the second drug being 0. But the combination of these two drugs will lead to a total effect of 200% or 2. And we tend to know this by, or see this by, um, the fact that one of those drugs tend to potentiate the effect of the second drug while not having its own separate activity. Typical example would be drugs like levodopa combined with carbidopa, or a drug like amoxicillin combined with clavulanic acid. In the case of levodopa with carbidopa, carbidopa tends to be the drug without any effect whatsoever, and carbidopa will be potentiating the effect of levodopa. Whereas in the case of clavulanic acid and amoxicillin, clavulanic acid is the drug that has no effect, and clavulanic acid would help in potentiating the effect of amoxicillin. If you are well familiar with drugs, you know the popular drug augmentin. Augmentin is just one of the examples of a potentiated drug with respect to pharmacodynamic interaction. It combines two substances, amoxicillin and clavulanic acid, and the clavulanic acid here is potentiating the effect of amoxicillin. So amoxicillin would have an effect of 100%, clavulanic acid would have an effect of 0, and the combination of these two drugs, which is augmentin, would have a combined effect of 200% or 2. And that's why augmentin is one of the very strong antibiotic that we use in curing multiple infections. The third outcome of pharmacodynamic interaction is synergism. Synergism involves the enhancement of an effect by one drug when we combine it with another drug. These two drugs, it's important to know that they have individual effects, but once we combine the two drugs together, the effect we see is really a supramaximal effect. It's an effect that is beyond our expectation. And we tend to always remember this by the fact that one drug would have 100% effect as one. Second drug would also have 100% effect as one, but the combination of these two drugs will give us greater than 200% effect. So let's say 300 to 400% effect, and than what we expect. Examples of a synergistic effect or synergistic pharmacodynamic interaction will be when we combine penicillin with with aminoglycosides, or we combine prednisolone with NSAIDs. The type of effect we see is not addictive. In this case, it's synergistic because we tend to see a supramaximal effect as a result. So combination of these two drugs, penicillin and gentamicin being an aminoglycoside, um, to treat, let's say, an infection would be extremely useful because the combination of these two drugs would lead to a synergistic effect, and the infection will be much treated quickly compared to when we're using these drugs individually. Last type of outcome that we can see for pharmacodynamic interaction is antagonism. Antagonism refers to the effect that results when we use two drugs concurrently, and this effect is described by the fact that one of the drugs would have an attenuation of its effect as a result of the presence of the second drug. And this is by virtue of the fact that when we're using these two drugs, though those two drugs tend to have their own separate effects, the effects that we tend to see tend to be opposing one another. So they tend to be opposite effects to each other. So one drug could have 100% effect, the other one will have another 100% effect, but these effects tend to be opposing to one another, and as a result, the combination of two drugs will lead to a submaximal effect, or less than 100%, less than one. Examples would be the combination of propranolol and salbutamol, or a combination of pilocarpine and atropine. In the case of propranolol or salbutamol, propranolol would antagonize salbutamol, and as a result, the effect of salbutamol will be submaximal. In the case of pilocarpine and atropine, atropine would antagonize pilocarpine, and as a result, the effect of pilocarpine is going to be submaximal. So this is the two drug combinations that typically explains or depicts the concept of antagonism, propranolol and salbutamol. Salbutamol is used typically in treating patients with asthma. It works on beta-2 receptors. And when we use propranolol, propranolol is an antagonist. It will bind on that beta-2 receptors and also prevent salbutamol from acting on those receptors. And as a result, you have a submaximal effect of salbutamol use because propranolol is blocking its activity. This is one reason why we don't tend to prescribe propranolol to patients that are asthmatic. So if you have a scenario where we need to prescribe two of those drugs, let's say a patient that is hypertensive and as well asthmatic, that patient would have been on salbutamol and would need an antihypertensive agent like propranolol. In the case of a patient like that, we will be avoiding propranolol because propranolol would reduce the effect of salbutamol, and that can worsen the patient's asthma symptoms as a result. There are three major types of antagonism that we see for pharmacodynamic interaction. The three types of antagonism we see are chemical antagonism, physiological antagonism, and pharmacological antagonism. Chemical antagonism is a type of antagonism that involves a concurrent use of two drugs, an agonist and antagonist, that would form chemical reactions. And these chemical reactions that they form would tend to neutralize the effect of one another. So, a typical example would be the use of drugs like deferoxamine and iron. Deferoxamine would combine with iron, forming a chemical reaction or a complex, and as a result, they will both neutralize their activity. Deferoxamine will neutralize the activity of iron, and vice versa. So as you can see in the case of the use of deferoxamine and iron, deferoxamine in the case is a chelator, and iron there is a metal. The combination of those two drugs used concurrently would lead to a chemical reaction called chelation therapy or chelation reaction. And as a result, what happens is that the chelator, deferoxamine, would combine with with the metal iron, and their combination will form a chelate or form a complex. And this complex will be removed out of the body. As a result, the metal or the iron will not be able to do its function. So this picture depicts what I talked about regarding the chemical type of chemical interaction or antagonism that we can see. The use of deferoxamine will combine with iron and lead to a complex, and as a result, this would inhibit or antagonize the effect of iron in the body. Physiological antagonism is the second type of antagonism. In this, we have the concurrent use of an agonist and antagonist. But in the case of the agonist and antagonist being used, it's important to note that these two drugs are going to be acting at independent sites. That's the keyword to remember for physiological antagonism. They act at independent sites, but they produce opposite effects by acting at independent sites. Typical example is the concurrent use of drugs acetylcholine and adrenaline. Acetylcholine as a drug or as a neurotransmitter typically will be working at cholinergic receptors. Norepinephrine, on the other hand, would work at adrenergic receptors. These two drugs or these two substances are involved in the activation of the sympathetic and parasympathetic nervous system. Acetylcholine would activate the parasympathetic nervous system. Norepinephrine would activate the sympathetic nervous system. So if we have drugs that tend to mimic this, so cholinergic drugs or like that mimics acetylcholine or adrenergic drugs that mimics norepinephrine, if they are being used concurrently, these drugs are going to be working at separate sites. One is going to be working at the parasympathetic site, the other is going to be working at the sympathetic site. And remember that sympathetic and parasympathetic nervous system tend to oppose each other. So the use of these concurrent drugs working at different sites will oppose each other. And this is a typical example of a physiological antagonism. The last type of antagonism that we have is the pharmacological antagonism. In this, we have the concurrent use of two drugs, an agonist and an antagonist. And compared to the physiological antagonism, for pharmacological antagonism, these two drugs are going to be acting on the same site. So we have the same receptors where these two drugs will act. One of the drugs is going to be an agonist to that receptor, so it's going to stimulate the receptor and lead to a maximum or submaximal effect or response. The other drug is an antagonist and it's going to be acting on the receptor, but it's going to be blocking the receptor. There are two major subtypes or subgroups of pharmacological antagonism. There's what we call competitive antagonism and there's what we call non-competitive antagonism. For competitive and non-competitive antagonism, it's important to note the differences between each of them. In competitive antagonism, what we tend to see is that the antagonist and the agonist tend to act on the same sites, or what we call the active site of the receptor. And as a result of acting on this same site, we tend to infer that the agonist and the antagonist can compete for the site, hence the name competitive antagonism. For non-competitive antagonism, the agonist and antagonist are going to be acting at separate sites. So the agonist might act at the active site, whereas the antagonist will be acting on a different site, let's say a site called the allosteric site or somewhere here. And as a result, because they are working at different points on the receptors, we say that they are not competing, so they are non-competitive. Because of the agonist and the antagonist tend to act at the same site in competitive antagonism, this type of antagonism can be reversed. It is reversible because if we have the antagonist working on one side and we increase the concentration of the agonist can displace the antagonist from the active site and as a result can reverse the effect of the antagonist. In the case of non-competitive, the type of antagonism that we see is irreversible because they're acting at separate sites. So the increase in concentration of one of the drug, let's say the agonist, will not have any effect on the antagonist at the separate site in which it is acting on. These two major types of antagonism can affect two of the parameters that we discussed when we talk about the dose-response relationship. Remember the Emax and potency or EC50. In the case of competitive antagonism, the Emax tends to not be affected at all. And in the case of non-competitive antagonism, the Emax tends to decrease. In the case of the competitive antagonism, the EC50 or potency tends to increase. For non-competitive antagonism, the EC50 or potency is not affected. This is a graph, a popular graph that tends to show the relationship between antagonist and an agonist with respect to competitive antagonism. As you can see, in the case of this particular chart, the agonist here is acetylcholine. So acetylcholine or by itself, given by itself, will lead to this particular log dose response curve. When we combine acetylcholine with a competitive antagonist, with an antagonist rather like atropine, because atropine and acetylcholine are going to be working on the same site, what will happen is that it's going to shift the potency forward, is going to increase the potency or increase what we call the KM. The KM and the potency tend to mean the same thing. So it shifts the KM or shifts the potency or shifts the EC15 forward. So there's an increase in the EC15, but the efficacy or the Emax of these two graphs will remain the same thing. So the same efficacy is going to be maintained 100%. So there's no effect, there's no effect on efficacy or Emax, but there's an increase in EC50 or KM or potency as a result of competitive antagonism. And this chart shows us the effect of a non-competitive antagonist with respect to the log-dose response curve. And the drug in this case is epinephrine. When we use epinephrine all by itself, it will give us this particular chart or curve, log-dose response curve, as you can see. When we combine epinephrine with another substance that leads to a non-competitive antagonist like dibenamide, what we'll tend to see is we'll see a reduction in the Emax. The Emax has dropped from 100% to 60%. If we increase the dose of the non-competitive antagonist further, we'd have a further drop in the Emax as a result. So Emax or efficacy tends to reduce when there's a non-competitive antagonism going on. Contrast this to the EC50. EC50 remains the same for all three cases. So it remains the same whether we are giving an antagonist, a non-competitive antagonist, or whether we're just giving the drugs or the agonist itself. So the Emax, the EC50, the EC50 rather, the potency and the KM all remain the same as a result. And this is evidenced by this particular point. And this is a case study for you to try out. In the presence of naloxone, a higher concentration of morphine is required to elicit full pain relief. Naloxone by itself has no effect. Which of the following is correct regarding this medication? A says naloxone is a competitive antagonist. B says morphine is a full agonist and naloxone is a partial agonist. C says morphine is less efficacious than naloxone. D says morphine is less potent than naloxone. E says naloxone is a non-competitive antagonist. So if you read the question very well, it says the presence of naloxone, a higher concentration of morphine is required to elicit full pain relief. Naloxone here is going to be antagonizing morphine, and if we require more dose of morphine to cause pain, it means that morphine and naloxone are competing for the same binding site, because morphine can displace naloxone from the binding site and thereby produce full pain relief. So as a result, we say that naloxone is a competitive antagonist, and we'll be going for option A. Second case study says in the presence of precotoxin, diazepam is less efficacious at causing sedation regardless of the dose. Precotoxin by itself has no sedative effects even at its highest dose. So this is a typical example of a non-competitive antagonist because the precotoxin and diazepam tend to antagonize each other pharmacologically at the same binding site. But precotoxin or diazepam is less efficacious regardless of whether we are increasing the dose of diazepam when there's precotoxin present there. So precotoxin and diazepam are going to be acting at separate binding sites, and as a result, further increase in diazepam's dose or concentration will not lead to more effect because they are not competing for each other. So we can say that precotoxin is an example of a non-competitive antagonism. So go with option E. And that concludes our module on drug interaction.